Welcome back. Today we'll be discussing Chapter 34, which discusses geriatric emergencies. I will let you know this is one of the shorter chapters that we will be discussing, but this is the vast majority of patients that we tend to deal with are those in the geriatric community. So even though this is a short chapter, this is a very important one to understand because it has to deal with the majority of our clientele that we see. Only one topic to cover today, and it's the geriatric patient. So let's jump in. So bad news, if you're over the age of 30, generally speaking, that means you are past your prime. So after age 30, your organ systems lose about 1% of function each year. That's a moving target. It does depend a lot on who you are, your baseline activities, genetics, a whole host of things, but generally speaking, about 1% of function each year after age 30. One thing that we do watch out for is your maximum heart rate declines. So the general rule of thumb to follow is your maximum heart rate is 220 minus your age. So if you are age 30, 220 minus 30 would be 190. That is the maximum heart rate that you should be able to achieve. So what does that mean? Your heart absolutely can go faster than 190. The issue is it's after it goes over the 190 mark at age 30, it's then going so fast that it can't keep up with itself. So it can't refill itself in time to pump the blood. So you actually have cardiac output decrease after you hit that 190 threshold. So if you go over 190, you start to almost decompensate because your heart can't keep up with its rate. So that's something to keep in mind when we're dealing with a patient that has tachycardia, is use the 220 minus their age rule, and that should tell you if the tachycardia is something very concerning. So like if it's a 70-year-old with a heart rate of 150, that's right at the maximum that their heart should go, versus if it's a 20-year-old with a heart rate of 150, they've got plenty of room to go up. So if they're working out or whatever's causing their heart rate to be going up, they've got plenty of room for their heart to still be effectively pumping. So that's the 220 minus age rule. When you get older, your compensatory mechanisms for shock begin to decline. So that means you're going to decompensate quicker. So it's very important that we need to trend vitals and see even the smallest bump of trends, because the room for compensation is going away quite quickly. So if you miss a trend for 5 minutes, the patient may have already gone through their entire compensated period and they could go into decompensated shock. So it is very important to keep on trending these patients constantly. There are some issues that come with communicating with older patients. A lot of them have difficulty with their hearing, vision, or memory. They also might have difficulty with a certain part of their body as a residual effect of a stroke. So they might not be able to move their right side easily or have sensation on one side or what have you. One thing that we really need to watch out for is please don't assume that a patient will have difficulty communicating. So talk to them like a normal patient at the start. They are going to be very quick to say, I can't hear you, or I'm hard of hearing, or I can't see you very well. They'll let you know if you need to change how you're communicating with them. But it's a little demeaning to a patient to walk into their house and start screaming at them because you assume that they're hard of hearing. So always start with the same level of treatment that you would give any other adult patient. And if you need to amend it to because they need to hear you better or see you better or whatever, that's when you take those steps. So some general issues with geriatrics with EMS. Geriatrics tend to use EMS much more often for basic services. So we're going to geriatrics a lot. It does go beyond your routine medical calls. They do have a lot of lift assists that we're called for, which could be considered a medical call because they cannot get up on their own. But there's a lot of times that they call us for non-medical complaints. They'll call us because they need assistance with their medications, which could be considered a medical complaint, or they need assistance doing something around their house and they don't know who to call, so they call 911. We are sent to a whole host of odd issues because EMS tends to be the catch-all for anyone who's geriatric to help. So be prepared to help them with a lot of social issues, a lot of issues with living at home, and a lot of things that you won't see with a normal adult. Now, whereas a lot of those calls for our services are warranted and it's just part of the job dealing with geriatric patients, you do need to recognize when geriatrics are calling 911 purely for social interaction. There are a lot of elderly people who live alone and they get lonely. It's especially apparent around the holidays where they'll hit their medical alarm button or they'll call 911 and then they just don't want you to leave. They won't want to go to the hospital. They just want to talk. So there's a certain point where you need to remind them what EMS is for. If it's just purely social interaction, it's appropriate to remind them that we are an emergency service, and then try to think of some ways that they might be able to enjoy social interaction outside of you guys. So try to recommend some groups that they could join or anything in your area, especially geared towards senior citizens, something that will get them some social interaction, because unfortunately nothing will prevent them from calling us if they really want to call us. It is hard for us to understand their baseline quality of life and how they're dealing with it. No one wants to be a burden to anyone. No one wants to get old and be fragile and frail. So it's hard for us to really relate to them, but try to understand that most people in their position don't want to be in their position. They led wonderful, great lives. A lot of them had phenomenal careers and have tons of great stories, and they just are in a bad position now, which none of us want to be in. They never want to be in that position. So just try to keep that understanding that this isn't who they were for 65, 70 years. So it might help you get through some of the tougher calls where you get a little frustrated that they might be abusing the system. Now, this picture serves to remind you that these patients are adults. They are true patients. A lot of times we fall into the trap of just talking over their head to the family about them and asking family questions, because sometimes it's easier because family can hear you better and it's easier to understand family. But that is very disrespectful to the patient. So whenever possible, try to communicate directly with the patient rather than asking others about them. Sometimes we can be very good at this, but then the family is not very good at it, because you ask the patient a question and then the family starts answering, and the family could be answering incorrectly, especially if you're asking about how the patient's feeling. The person who can tell you how they're feeling the best is the patient. So sometimes you have to remind family that whereas you appreciate their input, you want to hear the answer directly from the patient. So it does work both ways. So going into the history and assessment of the older adult patient, when we're doing a scene size up, you're doing the size up of safety both for you, like you always do, but you're also looking at the general scene and seeing how safe is the residence for the patient to stay in. This will give you clues about the patient's physical and mental abilities, and also give you clues as to, can this patient remain in this residence? There are a lot of times when a patient should be in some sort of assisted living or nursing home, and they either don't know that they need that assistance or they refuse to admit that they need the assistance. So that's where we can come in as a patient advocate and at least pass a message on to the hospital saying, these guys really should not be living in the house. They really need some social services help to survive outside of the hospital. So that does fall on us, because we are the ones who actually enter the residence. We could be the only ones in the past 5 years to have entered that residence, depending on how close family is. So don't take that responsibility lightly. Some other things that your scene size up can tell you is look at the condition of the residence. See if there's like half-eaten food, if the house is filthy, if it looks like no one's able to clean the house, if there's items that are thrown about that the patient can trip on, or like loose rugs or cords that the patient can trip on. Try to prevent your next call to that house. So any safety hazard to the patient, try to identify and prevent that, and then use all the information you glean to tell you how is this patient doing physically and mentally. Going into your history taking, look for previous medical records. A lot of times they're going to be near the fridge or on the kitchen table. Can't tell you how many times that there's just stacks of previous visits that have the entire list of the patient's medical problems and their medications. A lot of times geriatrics have so many problems and so many medications that they don't remember the names of everything. So if you have a medical record, that will help greatly in finding out what's actually wrong with the patient and their history. Keep in mind that these patients usually have a significantly long medical history, and it's going to take some time to get all that information down. That's part of the job. That's part of dealing with geriatric patients, is it's going to take longer. If you show up to a 20-year-old male with abdominal pain who's never had a medical problem before, your history taking is going to be a whole lot quicker than the patient who has 30 diagnoses and takes 40 medications a day. Those are two separate patients. They require two separate types of calls. So you're going to spend a lot more time on scene with these patients to get all the information that you need. And then also find out, is the patient compliant with medical advice? A lot of patients don't follow medical advice either because they don't want to, because they don't think that they actually have that issue, or it could be financial burdens. I know my grandparents, when my grandfather was alive, he didn't get insulin for my grandmother because he thought it cost too much and thought that she didn't have diabetes. She very much so had diabetes, so she went 2 to 3 years with a blood sugar of 500 to 600 because she didn't get her prescribed insulin. But if you looked at her medical history, you'd see she was prescribed insulin and she had a history of diabetes, so you would assume that she would be compliant. So it's sometimes hard to get this information, but keep that in mind that just because they have medical advice or they have prescriptions doesn't necessarily mean that they are taking them. A good resource is family members. I know we just talked about making sure that you talk to the patient directly. It's okay after you talk to the patient and communicate and get all the information that you need from the patient to ask follow-up questions to the family members. A lot of times they'll volunteer that information while you're doing the assessment. They will interrupt the patient to say, no, they don't do this, or they have this. So you'll oftentimes get that information already, but if you need to follow up with family, absolutely do that. So some things to keep in mind, that geriatric patients are very fragile. So minor traumatic events are much more significant to them. Just falling from standing for someone who's 25 years old, they'll stand back up and they'll be fine. Falling from standing for someone who's 95 years old, that could be a multi-system trauma. So the smallest things need to be taken very seriously. One thing that can make any sort of traumatic event worse is if the patient is taking blood thinners. That can cause a whole host of issues. For starters, if they have any laceration, even if it's a mild laceration, it's going to need some advanced bleeding control techniques to stop it. So don't be afraid to do your pressure dressings to reevaluate, make sure it's not bleeding through, because the smallest lacerations are going to bleed a lot. It takes a lot to actually stop these bleeds. Another thing about blood thinners is it can cause internal bleeding, particularly in your brain. So older patients are more susceptible to falling. If they struck their head at all, there is a very good chance that they started a bleed inside of their head. The issue with bleeds inside your head is they don't present right away. It usually takes several hours for symptoms to present from a head bleed. And when we show up, we're like, oh, I fell down, I just need help getting up, and I'll be fine, I don't have any complaints. And we could miss them having a head bleed, which they could go back to bed and then bleed out in their head and die in their sleep. So anyone who hit their head from a fall really should have a CT of their head, especially if they're on blood thinners. Because if they're on blood thinners, if they did start a bleed in their head, the chances of it stopping is much, much, much lower than someone who is not on blood thinners. If the patient hit their head but they don't take blood thinners, you have a little bit more room for safety with them. I still highly recommend that you take them to the hospital. Obviously we can't do anything against their will, but you can communicate to them the dangers of hitting your head and not going to the hospital, not getting the CT to make sure you're not bleeding. But anyone who is on blood thinners, really, really, really push as hard as you can to get them to go to the hospital. Again, you can't kidnap them, but really try to explain to them that this is a life-threatening thing that happened and you need a CT to make sure that they're going to wake up in the morning. Another thing to keep in mind is that their skin is very fragile. It can tear very easily. So handle patients carefully. If you grab them by the arm suddenly, you can tear their skin and it's going to start a significant bleed. A lot of older patients have altered mentation from several different causes. They could at baseline have altered mentation. If they have dementia, their baseline will be altered. And unfortunately, this can cause patients to be combative. So make sure that you are being safe. Unfortunately, the most number of patients that I have restrained in my career have been geriatric patients because they don't know what they're doing. They become very combative and very aggressive. They cannot refuse care because they are not alert and oriented. So we have to take them to the hospital, and they're going to fight on the way to the hospital. So unfortunately, that's when restraints are going to become necessary. So just keep that in mind that these patients will become combative sometimes, and to just keep an eye out. I don't want you guys getting hit or hurt because you were caught off guard by this sweet 98-year-old woman who everything was fine, but then you take her out of her home and she starts freaking out because she has dementia and she doesn't know what's going on. When you're doing a physical exam of geriatric patients, there are a few things that we should be looking out for that we don't usually look for in other patient demographics. One thing is pressure ulcers and shingles breakouts, which I'll show you pictures of those in the next coming slides. Also, these patients are prone to have edema in their extremities, particularly their legs. Remember, edema is swelling. That is a good indication of poor heart function. They probably have congestive heart failure if they're having edema down in their legs. So just keep that in mind that if you see edema present, then you have to be on the lookout for other complications of CHF, which could include like pulmonary edema, which turns to respiratory distress. So just keep an eye out for all that stuff. Also, you want to keep an eye for the frequency of urination and bowel movements, similar to pediatrics. That can tell you if a patient is well nourished and or dehydrated. So those are some better key things to watch out for. A lot of geriatric patients do not drink enough water and they do become dehydrated. So most of them, not most of them, but a good number of them kind of stay in a constant state of dehydration. So, like we just mentioned, pressure ulcers are something that we need to watch out for. Pressure ulcers come from laying in bed in the same place for a long period of time. That causes your skin to deteriorate. In young, healthy people, that will take days to happen. But for geriatrics, it can happen as little as 2 to 3 hours. This is something that we typically see in people who are bedridden and cannot move at all. This is why people are supposed to come in every hour or so and roll the patient or rotate them, move them around, do something to change the skin position on the bed. Unfortunately, especially in large facilities, sometimes this does not happen as frequently as it should, and so pressure ulcers tend to develop, especially in long-term care facilities. Right here is a picture of a pressure ulcer. And right here is a picture of the shingles rash. Shingles rash, hopefully in the next 50-ish years, will kind of go away. In order to have shingles, you really need to have chickenpox as a kid. And with the development of the chickenpox vaccine, hopefully we're going to see less and less and less geriatric patients having shingles break out in their life. But this is going to be something for a few more decades that we're going to still see. It is incredibly, incredibly painful. As far as them laying down goes, there are a lot of people who have permanent deformities to the spine. One of the more common deformities is called kyphosis. I'll show you a picture of that in the next slide. And just keep in mind that you may need to have extra padding available to make the patient comfortable. A lot of these patients are incredibly uncomfortable and in a decent amount of pain when they're on our stretcher. Our stretcher is not a comfortable thing for most people, period, but if you have deformities, especially to your spine, it's going to be almost torture to be on our stretcher. So right here is a picture of a normal spine versus a kyphotic spine. So you can see how kyphosis kind of gives you almost a hunchback, then comes back in. It makes it very hard to lay flat on your back. You can see how a flat stretcher would be very, very bad for these patients. When you had to put these patients on backboards several years ago, when we used backboards a lot more, it was pure torture for them. And you can see why, the spine is not meant to be on a flat surface when you have kyphosis. So reassessment is very important with geriatric patients. It's very common for geriatric patients to have a slow, steady decline in condition. It's not going to be rapid changes like you might see with younger people. You might see in a 5-minute period of time a heart rate change of 10 beats per minute. But then in the next 5 minutes, you have another 10 beats per minute. So in the next 5 minutes, you have another 10 beats per minute. It's slow, but it's significant. So you might be lulled in a false sense of security saying, oh, they look fine. They're not much change in their vital signs. But if you trend for a long period of time, it's going to be a significant change in your vital signs. So just keep on reassessing everything, make sure nothing's changed, reassess their mental status. A lot of them want to go to sleep, especially if you have a longer transport. It's hard to reassess your patient's mental status if they're sleeping. So if you have any concern for this being a significant medical event, it's really best to stay talking with them, making sure that their mentation is still intact. So another thing to watch out for is how emergencies present in geriatric patients is a lot different than how they present in younger patients. A lot of geriatric patients have decreased sensations, so they might not feel the same things that someone who's 40 or 50 years old might feel. Some of them will just have a mild stomach ache, and that mild stomach ache actually is a myocardial infarction. I've had that happen more than once where it's just mild GI distress and it turns into becoming a STEMI. So it's a very hard group to treat because you can't rely entirely on their complaints because they might not feel the pain that you should feel with some of these medical emergencies. Just keep that in mind that the smallest complaint should be taken very seriously with geriatrics. So I touched on this earlier. Compliance with medications becomes a much bigger issue in the geriatric population. There's a whole host of reasons why they might not take their medications. Sometimes they can't afford them. Sometimes they don't understand why they need them. And sometimes they take it and they just don't feel well, so they just stop taking it and they don't tell anyone. So it can be a whole host of issues and it can cause them to not be taking what they really need to stay alive. The grandfather I mentioned earlier, he had a history of blood clots, and so he was prescribed blood thinners, but he was terrified that if he cut himself, he would bleed out and die. So he just didn't take his blood thinners. He ended up having a massive stroke and ended up dying from that stroke, probably because he wasn't taking the blood thinners to prevent the clot from happening. So it wasn't rational at all, but to geriatrics, sometimes they don't make the most rational decisions. So just keep that in mind that a lot of times, even though they have the medications, it does not mean that they are compliant with their medications. Some things that we have to look out for in the geriatric population is drug-patient interactions. So sometimes when you get older, you cannot clear the medication out of your system as effectively as a younger person could. So that could cause a buildup of the effect of the medication because you're just not getting rid of it as fast as you should. Another thing that can happen is called drug-drug interactions. That's when two drugs interact. That's very common to happen with geriatric patients just because of the sheer number of medications that they take. Here's a little picture of a very typical nightstand of a geriatric patient. And it's also important to know when you take this many medications, screwing up what you're supposed to take and when, and possibly losing a vial and not realizing it, that's a very real thing that can happen. So we do see a lot of prescription drug issues come up, whether you're missing doses or doubling doses or taking them at the wrong time. You can have a lot of issues. So that's why it's very important to look at all the medications that the patient has, because having a screw up in the medication could be the reason why you're there. It could have caused the abdominal pain that they have, or the dizziness that they have, or the augmentation that they have. So it's very important that we record all the medications that we see. Geriatrics obviously experience a number of medical emergencies. So a lot of this course is geared towards taking care of these medical emergencies. So just go back to your training, try and remember all the different things that could happen to the body. And also remember that more than one emergency can happen at the same time. So just because someone's complaining of chest pain doesn't mean that's the only thing they're having. A very common thing to have happen is a respiratory and cardiac emergency happening together. So you can have chest pain and shortness of breath. You could have altermentation and a COPD exacerbation at the same time. So just because you have one differential diagnosis does not mean that's the only issue that's going on. So dizziness, weakness, and malaise. Malaise is a medical term for kind of just general sickness, generally not feeling good. These are the bane of some people's existence because they're very general complaints. They don't point to one thing specifically wrong. It's very hard to differentiate what's causing dizziness, weakness, or malaise. With geriatric patients, though, we cannot take these complaints lightly because they can be a number of serious conditions and they could be life-threatening. Dizziness alone could be caused by cardiac distress. You could be having a myocardial infarction. It could be caused by a stroke. I've seen multiple instances of strokes with the only complaint being dizziness. Weakness could be the result of cardiac insufficiency. So even though they seem like very mild complaints, it could indicate something very serious. So be very diligent in your assessment, even for vague symptoms. Even if the patient just says, I don't feel myself, I don't feel right, I just feel kind of run down. That could be a sign of something very significant going on. When you are called for a person who fell, notice I said when, not if, that we go to falls all the time. So it's very important to find the cause of the fall and then treat for the cause of the fall as well as the injuries. So was the fall caused by a trip? If it was caused by a trip, then make sure that they don't have that tripping hazard again if you can prevent it. But that shouldn't be something medical to treat. Versus, did you fall because you lost consciousness? Then there's a medical condition to treat of a syncopal episode. Or did you fall because you're feeling dizzy? So just find out what caused this fall. Again, have that high level of suspicion anytime the head is struck. Really, really, really encourage these patients to go to the hospital. Even if they're feeling fine, try to encourage them to go to the hospital and get a CT scan. Depression and suicide is in record numbers in the geriatric community. It is one of the real unfortunate realities that geriatrics go through this. It can be caused by a whole host of issues, such as having conditions that limit activity, not being able to do what they used to do, feeling a loss of self-worth, especially once they're retired. Financial burdens are coming up, medications that take your energy away, having the loss of friends or a spouse, or just plain biochemical imbalances. It can be caused by numerous things, but it is a very common thing to see is depression and suicide, and be very cognizant of that. Your interaction with this patient could be the only human interaction they've had in the past month. So be aware of that. Be very nice to these people. Unfortunately, geriatric patients are the target of much abuse and neglect. There are three major ways that geriatric patients are abused or neglected. You have physically, psychologically, and financially. It is harder to detect these things because you just assume that they're an adult, they'll be able to fend for themselves, but a lot of times they don't know that this is happening. Physical abuse is usually the easiest one to see. That's when typically happens when a caregiver or a family member gets frustrated and they take it out physically on the patient. But there's a psychological abuse that oftentimes comes with family or caregivers saying how much of a burden they are, how they wish that they weren't around anymore, things that really send them into depression. And then there's financial abuse of just outright stealing from the patient. We've all seen all the warnings about these scams that come across. So financial abuse could come from an outside source of a scammer, or it could be a family member who just comes in, takes money, or lies about why they need money, and the patient wants to help the family member, so they give the money. So it is very hard to detect, but if you feel like you suspect abuse or neglect, report to the hospital and then report to the Division of Social Services. Most counties have an Adult Protective Services division, so that's who we would be reporting that to. So when there's a married couple, oftentimes there comes a point where one spouse becomes the other spouse's caregiver. This can cause a lot of issues. If they are both having medical problems, the original caregiver is going to neglect their care a lot of the time because they're so focused on taking care of their spouse, and that can result in the decline of both people very rapidly. You can also have caregiver guilt or burnout. Can happen very easily when you kind of get sick of taking care of the spouse, or you feel like what you're doing is not enough. So it's something that you need to keep an eye on, and again, report to the hospital, especially if they're providing insufficient care. Report to the hospital that something needs to happen, and hopefully social services can intervene with that. So loss of independence is an unfortunate reality with geriatrics. Most geriatrics will not accept the fact that they can no longer care for themselves. They feel like they are doing perfectly fine, and that's because no one's told them different. Again, sometimes we are the only ones in their residence for the past year. So it's very important to take a look around and make sure that they are actually capable of taking care of themselves. A lot of times they will never admit that they're not, and sometimes they don't realize that they can't. So we do have to be the advocate for the patient who we see living in poor conditions. Always treat the patient with dignity and respect, but we also need to advocate for them, especially if they can't advocate for themselves because they don't realize that they're in a poor situation. Let's go into a little bit of chapter review. Age-related decline in system function alters the body's response to illness and injury, requiring modified interpretation of assessment findings and complaints. Multiple medical problems and medications can lead to unpredictable problems and drug interactions. Changes in the nervous system, along with isolation, financial problems, loss of loved ones, and chronic health problems, all increase the risk of depression in the elderly. Depression can interfere with a person's self-care and ability to communicate. So you are called to the nursing facility for an 85-year-old female who is having trouble breathing and is very confused. What do you suspect may be wrong with this patient? What actions would you take in treating this patient? So this patient, it's kind of hard to say with limited information. You have to assume that right away that the trouble breathing could be the cause for the confusion because they're hypoxic. So the first thing that you would start is treating the respiratory complaint. So giving oxygen, diving deeper into the difficulty breathing and finding the cause for that. Then you're going to be seeing if the mentation improves while you're treating the difficulty breathing. Hopefully it does. If not, you need to treat the confusion as a second medical complaint. So unfortunately, there's not too much information with this question to really give much more of an answer beyond that. So that does bring us to the end of this chapter. Like I said, it was a relatively quick chapter, and unfortunately it does deal with the majority of our clientele. So this is all stuff that you really, really need to take to heart and to remember, because this is something that you're going to be dealing with on a day in, day out basis during your career as an EMT. So until next time.